Now, this is the talk on basic knowledge in infection control of the SARS epidemic in 2003. Emerging infections are the diseases that are newly recognized during the last 20 years that cause public health problems locally or internationally, and they include SARS, MERS, highly pathogenic avian flu, Ebola hemorrhagic fever, Japanese spotted fever, and AIDS. They are all familiar names, I think. And you might wonder whether or not it was really the last 2 decades that AIDS was seen. But in fact, this definition by WHO was first announced in 1990. That means it's 20 years back from that time. It's not 20 years back from now. So in reality, emerging infections that occurred after 1970 is included in the definition. So if you count from now, it's the new infections that appear in the last 5 decades. Re-emerging infectious diseases are the known infections that see increase of patients in the last 2 decades, namely since the 1970s, which had formerly fallen to levels so low that they were no longer a public health problem, such as malaria, dengue fever, tuberculosis, and rabies, which are again all familiar to you. So these were the definitions. SARS is caused by SARS coronavirus. It's different from the known coronaviruses, like the ones that cause flu syndrome. It's a new virus, and first it was said that it was transmitted from masked palm civets, but as they were isolated from that animal, so it came from animal to human. Originally, people say that it came from bats, but anyway, this is a rare route of transmission from animal to humans. But once humans are infected, it's spread quite rapidly in the cities and in the society. So it started with pneumonia, and it became quite severe, as you can see. And about 10% or less of the people infected die. That's the kind of disease. I was with Nagasaki University then, and I was seconded to WHO. I spent 1.5 months at China WHO office as an expert, and I joined the assignment to contain the SARS epidemic. Later, WHO published a book titled SARS, How a Global Epidemic Was Stopped, and I was involved with my name, with affiliation to Nagasaki University, and I was with the infection control team from 2nd of May to 15th of June. I worked for the team. I joined the team in the latter part of the epidemic and went to China. I spent days until the end of the infectious control in the epidemic region. When I went to China at that time, globally, this was how the disease was widespread. Already at that time, more than 3,000 cases of SARS was seen in China. In Tianjin and Hong Kong and in Beijing, there was a cluster of over 1,000 cases. A doctor from Guangdong stayed at the Metropole Hotel in Hong Kong. Travelers on the same floor were infected, and those travelers went back to various places like Canada, Singapore, and Vietnam. They flew, and in each of their destinations, infections spread, leading to an outbreak. So it started from China to Southeast Asia and then to Europe and also to North America. So this infection was quite widespread. In those days, WHO thought that because it was quite widespread, it would take at least 3 months or more for the infection to be controlled. But in reality, it was controlled earlier than that. When I was in Beijing, when I arrived, this is the international airport at Beijing, it was deserted. It's quite empty. And in the streets, you see almost no one. Most of the restaurants were closed. So frankly speaking, I just wondered where I should have my dinner. I felt quite anxious, and government told people not to go out because of the risk of infection. It's more like the condition of lockdown that we see now. In many parts of the city, you see banners like this. It says atypical pneumonia, and it's pronounced as SARS in Chinese. Globally, it's SARS, but in China, they call it SARS. This is the typical pictures, clinical pictures of SARS. The latent period is 2 to 10 days. At that point, because of no droplet, it's not infectious. Early symptoms mostly start with fever. Again, without droplet, it's less infections. And a few days after fever develops, you have lower airway symptoms like cough, developing droplets and become more infectious. So you have to check the fever, because fever precedes cough. So you do the screening with the fever. People with fever have to be isolated early. That was a very effective means. Later, we had new type of influenza. Whether or not the same could be applicable was a question. In case of influenza, people become infectious a day before the fever develops. And the COVID-19, in this case, people become infectious 2 days before the fever develops. So in these cases, since the patient is infectious before the onset of symptoms, for both influenza and COVID-19, you cannot control the infections, unlike in case of SARS, where you can isolate people when the fever develops. This is the list of clinical symptoms upon admission. 100% of fever, because it is included in the diagnostic guideline. You had the throat pain and running nose among 11 to 10% or 25% of the patients. Cough was seen between 29 to 75%, and surprising thing was diarrhea, 25 to 73%. There was quite a high frequency. This is the frequency of diarrhea during the first week. The frequency was relatively high, and in fact, if you look at electron microscope image, you would see that from the tissues there are viruses being released. So SARS is a respiratory disease, but guts are also infected, as you can see evidence from this. In those days, there were clusters, epidemics in large cities, and once you're diagnosed, you are isolated for a long period of time, and people didn't want that, so they went back to rural hometowns from large cities. The population then in China was 1.3 billion, so once spread to rural areas, they thought that it was difficult to control the disease. So the government and WHO joined hands to establish teams to prevent the spread to rural areas. Many inspection teams were established and sent to rural areas. I went to Honan and Hubei. First, I spent a week in Hubei, went back to Beijing, and then went to Henan again for a week. So you visit various rural hospitals to see the infectious control measures, and I joined such team. After inspection, we go back to Beijing, and we help prepare the revision of guidelines. Upper left photo is the photo taken with everyone in the team at the authority office. We have people from CDC, we have infection control nurse from nurse, we have epidemiologists, we had clinicians like myself, and from Chinese government we had epidemiologists, clinicians, and politicians. And we had a team to travel by air and by car. We went rural areas and we visited hospitals. Epidemiologists to check and inspect the reporting system. Clinicians, we check the diagnosis and treatment. We went to the wards to see whether or not treatment was properly done, whether or not there's a good infectious control. So we did carry out our functions respectively, and till late in the evening we prepared reports which we submitted to the hospital and to the local government as a feedback. We also submitted a report to WHO and national government. So these are the things we did. I spent 1.5 months in China. We worked on Sundays and Saturdays without any holiday. We worked every day. It was my first experience to work on weekends, but it was a very critical situation with the emergent infection. I didn't find it very difficult to work that hard. When you go into the SARS word, this is myself. In those days, China didn't have an inventory of disposable masks and gowns. Instead, they had the layered way of protecting themselves. You have trousers, you wear gown and boots, and then wear trousers, and you have shoes covers. So you have layered and layered of the PPEs. You have double masks, goggles, and double gloves. It takes you about 45 minutes to get ready like this. And of course, in a situation like this, you are very tight, you have narrow scope of vision, and it's hard to breathe. After 20 minutes, it's like you are in sauna. It's May, and to spread the virus to be prevented, air conditioning was stopped. So after 20 minutes, you are dripping with sweat. It's very difficult to work in a situation like this for hours and hours, but Chinese colleagues were working hard for hours and hours, and we had great respect for their efforts. It seems like there's no exposure, but you have some space around your eyes, around the goggles, so when you are to leave, the nurse will dab you with the iodine around your eye. I try to say and protest that it's meaningless to do this, but in the local hospitals, they had quite strict responsibilities to be carried out. So I was told I will never be able to go out of the site. So once in a ward and once you're out, you have to come out with the panda-like face around your eye. So there were some excessive measures taken. This is the spraying of disinfectants in the air to kill the virus in the air. It's not that the virus is airborne, it's the droplet transmission. I try to convince them, but people tend to like disinfection, and it seems like this has been their normal practice. And once you are out of the ward, you have to immerse the gloves and boots for 5-10 minutes in the disinfectant. That was what we were told. Disinfection means to reduce the number of pathogens, not to cause disease. Just because you have disinfection doesn't mean you have no pathogen. Sometimes you may increase the pathogen with the degraded, deteriorated quality. So this is the unnecessary process. If you can get rid of these properly, that would means you don't need to go through this process. And if you look at the ceiling, it may not be very clear, but you have a palish light. This is UV light. UV light is everywhere, even where people walk. The reason why I do this is that they have the data that with the UV light exposure from 1 meter, virus dies in an hour. And it is included in the guideline to use UV light. It's okay if there's no people. But if you use this where people move around, it leads to skin and eye damages. It's toxic to the human body. You really have to have the right way to use these systems, but people seem to be rather indifferent. At the time when the guideline was revised, ultraviolet ray issue was a point of much debate between Chinese and Western representatives, so I had to mediate their discussion. So there was some excessive means, but on the other hand, if you go to rural areas in the hospitals, they use the tongue depressors again and again after disinfecting. But you have pathogens in the mouth, so it is quite risky to spread the virus. So right away we told them to change these to disposable ones. In China, the government established SARS dedicated hospitals where only SARS patients are treated. It's a big hospital like this. In Tianjin, you have Haihe Hospital. It looks like it was a prefabricated building. It was made in just 3 days. Like in case of COVID-19, they mobilized a lot of people and built hospitals in a very short period of time. Even in those days, the practice was like this. They mobilized lots and lots of people and constructed hospitals in a very short lead time. And they had these fever clinics everywhere. This was a key for the surveillance system. You have the body temperature checkpoints at highways and airports, and those people are sent to fever clinic. People come their own, or people isolated at home with fever come to the fever clinic. So they were diagnosed as SARS, or they were considered probable or suspect or case under observation. They are classified, and at the entrance at the fever clinic, if you have symptoms, you are to wear a mask. The medical practitioners have PPEs, and in the waiting room, people are seated with 2 meters apart. Once diagnosed, they are put into isolated ward. And how many patients were seen, that information is sent to the government in just a few hours. So it's not just the diagnosis that is done at fever clinic, but epidemiological data is swiftly sent to the national government. So they had this reporting system. PPEs, caps, gowns, respiratory mask, N95, gloves, goggles, and shoe covers. It was then that PPE's importance came into understanding. There were hospital infections. We checked what measures those who were infected and those who were not infected took. The paper mask, some people were infected, although it was not statistically significant. And if there were surgical mask or N95 mask, no one was infected. There was a significant difference statistically. Even it doesn't have to be airborne transmission prevention mask. Surgical mask was enough to control, and hand washing was also effective. So major route of infection of SARS was known to be not airborne transmission, but it was droplet. And the use of PPE led to directly the difference in the number of cases among medical practitioners. Chinese government took a very stringent isolation policy. In Japan, we had thermography for airports, for border control. That was also practiced even at highways in China. On the lower left photo, This is the village isolation as a whole with a population of 3,000. A person returning from Beijing was infected and transmitted SARS to 2 family members. At that point, the entire village was isolated. Everyone had to stay home, and they had to measure fever 3 times a day. Meals were provided 3 times a day. So it's the village isolation as a whole. On the lower right, you have the 3 slogans by Hebei province. One is free treatment. Number 2, you have dedicated hospital. And the last one, this is about the whistleblowing. If you have someone around you who has symptoms suspected of SARS, please notify the government. If that person is diagnosed as SARS, you get the reward of 1,000 yuan, which is about 14,000 Japanese yen. You might think that's cheap, but because of the difference in the prices in those days, which was about 5-fold, this is actually like 100,000 Japanese yen being given as a reward. When I worked in China, I often thought about what measures Japan should take once SARS is introduced into Japan. However, this particular measure I thought was not possible in Japan. Even for the COVID-19, this same system is in place in China. WHO also has to engage in political events. This is a dinner party held by a mayor in the province. You start with a toast, and in Japanese it says kanpai, but in China it's called kanpei. There's a big difference between the two. When we say kanpai in Japanese, it means let's start enjoying the dinner. But when we say kanpei, it's the beginning of the ritual. The first one, you empty your glass, ensure that the glass is empty, and you repeat it 3 times. The first one is greeting, number 2 is eternity, the third emptying is eternity. That means you have to empty glasses 3 times for eternity, for eternal friendship. In Japan, I don't think the young people do this anymore, but if you are late in joining your party, you have to empty your glasses 3 times. That was the practice in the old time in Japan. It was okay with the beer, but in China, you have to drink strong spirits of 50 degrees. You might still be okay if it is a small glass of cup that you use, but actually you have 20-30 people. You have a long queue, and people are waiting for your turn. And if you continue this, you get drunk, and you would say you don't want to drink anymore, but then the Chinese people would say, why can't you do this with me? You did that with others. So you cannot say no to that, and you have to drink again. But there's a difference in the national character. A person next to me, she was from Australia. Kathy says, no, I'm not going to drink anymore. Unfortunately, as a Japanese, I couldn't say no. How can you cannot do this with me because you did that with others? And then I would have to start drinking again. You get dizzy, and suddenly you see the same face in front of you. It was the second round. The more you do that, you have a tighter, close friendship. It goes on, and you get totally drunk. You are carried to the hotel, and sometimes you wonder if this is the right thing in the epidemic region. This was the hardest work I had to engage in as a member of WHO. And finally, there was this clinical management workshop held in Hong Kong. This was the first international clinical meeting with the representatives of countries where SARS incident was reported. There was no one from Japan, because as a representative of the China office from WHO, I was the only Japanese taking part in this meeting. This is a summary of discussion then. This is about the PCR positivity. 1,400 cases were checked. Nasopharyngeal 50%, stool 44%, urine 5%. With all this, the positivity was 63%. It was not very high. Pregnant women had high mortality of 30%, and 80% had spontaneous abortion. There were pediatric cases of infection, but only 12% went to ICU with severe disease, and there was no case of death. Just like COVID-19, this is a disease which is new with no immunity, but the children were not getting severe. And people over age of 65, the mortality was close to 70%. It's like COVID-19. People become less feverish at the beginning. They had delusion and anorexia. There are atypical symptoms seen. And the same thing can apply with the pneumonia for elderly population. And this is about a treatment. Because it is a new disease with no therapeutic drugs, first people thought ribavirin was effective for COVID-19. Many things were tried, but ribavirin was not promising clinically. Although it is a preliminary data at that time, the combination with Kaletra, which is an anti-HIV medicine, was promising, and a clinical study is underway. With regards to steroids, the SARS can get aggravated with the cytokine storm, so at certain timing, steroid was effective in severe cases, but dosing and the route of administration or the length of administration should be considered further. 6 milligrams of dexamethasone for 10 days was effective for COVID-19, but in case of a steroid, the long-term use led to other diseases for severe cases. So we knew steroid was effective to some extent, but there was no final view on how it should be used. Now, talking about high-risk procedures, aerosol formation is risk. So when you have difficult intubation, or when you have mask ventilation, or people are on artificial ventilator, then the formation of aerosol is a risk that you have to pay attention to. On July 5th, 2003, there were 32 countries, 8,439 patients, and 812 people died, and it came to an end. Fatality is about 10%. After that, there were some cases in Taiwan, Singapore, and China among researchers who dealt with the virus, and there was a lab infection, and there was a case of death outside of the lab in China. So the researchers have to exercise even more stringent biosafety measures. After that, in Guangdong, there were cases of SARS. There were only 4, and because it was early, it was well controlled, and there was no further cases. But as you know, after 2012, we had MARS from Middle East, where those who traveled to Middle East, and in 2019, up until 11, there were 27 countries. About 2,500 cases were infected with 855 deaths. So far, in the last 2 decades or so, there were emergent and re-emergent infections. This is the list. In 1997, we had H5N1 avian flu virus. And in 2003, 6 years later, in Guangdong near Hong Kong, we had SARS. At that time, I thought that as I was involved in SARS assignment, I thought this was the first and the last occasion. But in fact, we had in 2009, we had H1N1 flu, and SFTS, MARS, and H7N9, and dengue, and Ebola, and COVID-19. So after every few years, we have a repeated incidence of emergent infections. Unlike in 2003, we need to face with COVID-19 for a while. Even if that came to an end, I would assume that there will be more emergent infections coming up. WHO have a go-around, which is a global outbreak alert and response network that we established. We have medical institutions across the world registered when there are problems. The local medical institutions and WHO are working together for registration system, and we also provide training courses. From Japan, more than 30 medical institutions are registered, including ours, and we also take part in the training courses across the world to be prepared for these incidences. At the moment, we are in the midst of corona pandemic, which is often compared with the Spanish influenza in the 1918s. The mortality was 2%, with a global population of 1.2 to 1.4 billion. 40 million people died, and people were afraid that the same thing could occur for COVID-19. But now we have antibiotics, we have antiviral drugs, we have technology for diagnosis, and overall we have experiences and knowledge for a variety of emergent infectious diseases, and we are all united. If we can collaborate together and work together, I'm sure we can overcome this COVID-19 and any other emergent diseases or any pathogens. I'm sure that human being can overcome that. Thank you very much.